Our next presenter, we've heard from already, Dr. Gary MONTEIRO. He's an anesthesiologist here at Methodist Hospital. Now, when I was 10, I woke up during a cath procedure to find out that I was taped down to the table, and I looked down and I saw my leg cut open as they were injecting dye into me, and I was x-rayed, and it felt like my hands were on fire, and I screamed. So your topic is, what does your anesthesiologist need to know? My short answer to that is, wake me up when it's over.
So it's what your anesthesiologist wants to know about you, and maybe what you want to know about the anesthesiologists who are going to be taking care of you, because it's interesting. They might not know anything about you. So objectives. So we're just going to discuss sort of the pre-op information that an anesthesiologist would like to know about an adult who's showing up with congenital heart disease. And then I'm also going to describe sort of the subset of anesthesiologists that are developing or being developed to take care of you as patients, because as we've heard multiple times today, the adult congenital population is a tidal wave. I don't have any monetary disclosures. I mean, you laugh, but this happens every day. So who is going to care for the adult congenital heart disease population? As far as your cardiologists go, there are sort of defined educational pathways. Cardiology, adult congenital fellowships. Surgeons have cardiac surgery fellowships, pediatric cardiac surgery fellowships, and then typically find themselves in a hybrid practice or one or the other. Anesthesia, we don't really have a defined pathway for adult congenital heart disease. After an anesthesia residency, you can choose to do a fellowship, which is an additional year or two of training. And there's CT or cardiothoracic fellowships. You can do a year of pediatric. There's PDCV fellowships, which is sort of an advanced fellowship. My path was a little bit different. I did adult cardiothoracic, and then I went and did PDCV fellowship, and then now I found myself in a completely adult practice, but taking care of adult congenital heart disease patients. We teach fellows here, and a lot of times my fellows they have said to me, how do I study for boards when I've never even seen this stuff that we're talking about? And then my thought is, how are you going to take care of these patients when you've never even seen the thing that we're talking about that you're going to be taking care of? And typically what happens is they go into private practice in a smaller hospital. A patient with an adult congenital heart disease issue shows up, typically for non-cardiac surgery, and then my phone starts ringing. But phone a friend is always a good idea. Again, there are guidelines. They're exhaustive on adults with congenital heart disease, 150 pages long if you want to read the whole thing. And there's a half a page on anesthesia in those 150 pages. Yeah, which is more than I was expecting. In these guidelines, they define adult congenital heart disease into simple, moderate, and then great complexity, which is a nice little system. And then here's an example of simple adult congenital disease. A patient that has had a ligated or catheter-occluded PDA. You've had a secundum ASD repaired, and it's no longer a big deal. And it says these patients can usually be cared for in the general medical community. The concept of moderate, and I'm sure some of you have these conditions that are listed here under moderate. You see tetralogy of Fallot. You see primum atrial septal defect. You see coarctation of the aorta, which we talked about earlier today. And then finally, complex heart disease of great complexity. These are patients who have conduits, Eisenmenger syndrome, pulmonary hypertension, patients with single ventricles. And these patients should be seen regularly at adult congenital heart disease centers is the recommendation. So what does that mean? When we're talking about referral centers for adult congenital heart disease, these are some of the recommendations of what should be available. And I just made cardiac anesthesiologists several available 24 hours a day, 7 days a week. I work with Huie a lot and Dr. MacGillivray, and they sort of know if I'm in town, I'm available 24 hours a day, 7 days a week. And my family really appreciates that. But we are, typically at institutions that take care of patients that have a specific subset of disease, there are sort of care teams that have developed over time where a surgeon, the anesthesiologist, the cardiologist, the OB/GYN that'll deal with, that's comfortable with these. We sort of talk and text each other. But you'll see there's lots of interesting stuff on here. Congenital cardiac surgeon, cardiologist that specializes in adult congenital heart disease. But the thing everybody forgets is all the other services that are always available at other hospitals, MRI, CT scan, you have to have faculty or staff there that are comfortable interpreting those images. It's not just putting you in the MRI scanner, it's reading those images and integrating that information into your care. So on that half page, there's some anesthesia recommendations. Surgical procedures that require general anesthesia or conscious sedation, if you have moderate or complex disease, should be performed in a regional center with an anesthesiologist familiar with adult congenital heart disease patients. Doesn't say what kind of training is involved. In the current fellowship guidelines for my fellows who are adult CV fellowship, it's encouraged that they have exposure to congenital heart disease. You know, it basically says it like that. Out of the following 4 things, one of which is congenital heart disease, the fellow should be exposed to it. So there's going to be a wide variety of interest, expertise, exposure to congenital heart disease. So these are just congenital lesions that have a higher risk when you go in for surgery, for any surgery. Clearly the highest risk category, sort of like somebody asked me a question about this earlier. It's going to be patients with pulmonary hypertension, patients who are cyanotic. The New York Heart Association thing means patients that are in heart failure. You can't walk a block. You can't go up a flight of stairs without getting short of breath. This ventricular dysfunction means that the muscle of your heart is weaker than expected. And then you have severe left-sided heart obstruction. There's some obstruction to when your heart pumps the blood. And then there's moderate risk. So it's interesting, when you look at anesthesia outcomes for adults that have congenital heart disease, there's not a whole lot of data because we don't have great registries. But there's one study here that I sort of liked, and it looked at outcomes when you go in for surgery that's not cardiac surgery, and you're an adult and you have congenital heart disease. And they compared 10,000 patients to a group of patients that didn't have heart disease, having things, knee replacements, tonsils, just surgeries we do every day. And as we know, the amount of surgeries we're doing that are non-cardiac surgeries in congenital patients is increasing as the population's increasing. And not surprisingly, when compared to your peers, you have a higher complication rate. So this first slide from this article just shows that over time, the number of surgeries happening in congenital patients is increasing. It looks like it's a huge increase, but it's like 0.06% to 0.18. So 3 times increase in number of surgeries out of all surgeries happening in 7 years. And it's going to continue to grow, we know that. But this is the interesting slide. On, I guess it's y'all's left here. This is the patients who have adult congenital heart disease. And on the right side, it's being compared to patients having the same procedures, same age, et cetera, but that don't have congenital heart disease. You'll notice that for every single category except death, there's a significant increase in these things happening to the adult congenital heart disease patient. So for example, you're gonna stay in the hospital longer, most likely. The procedure and the hospital costs are gonna be more expensive. Injury to the kidneys, pneumonia, respiratory failure, just having a DVT, neurologic complications. So very enlightening. And I think some of the takeaways from this article were there are no formal guidelines on, but it's widely accepted that care teams of anesthesiologists, surgeons, cardiologists that care for you, if you have moderate or severe disease, if you have simple repaired disease, I don't think it's that much different. But these care teams should be taking care of you when you come in for surgery. And something I always try to impress on my anesthesia trainees who are actually interested in adult congenital heart disease, because a lot of anesthesia trainees and folks run from adult congenital heart disease because they perceive it to be an increased risk or they don't have a comfort with it, et cetera. But you always have to remember that congenital heart disease is a lifelong systemic process. It's not you had surgery when you're a baby and it's never going to affect you again. There are, this is something that you need follow-up, and it's going to follow everybody for the rest of their lives, which is okay because there are people that love to take care of you. And improvements in people's outcomes are only going to be achieved through a team approach and multidisciplinary discussions between the surgeon, your primary care docs, your cardiologist, and your CV anesthesiologist. So now I'm going to move up. So that's what you need to know about anesthesia. And now we're going to move on to what does anesthesia want to know about you? So I always talk about hitting people with a hammer every time they wake up. This is a rock. But team approach again. If you have severe or moderately severe congenital heart disease and you're going in for an operation and you're meeting an anesthesiologist on the day of and your cardiologist has never spoken to them and the surgeon's never spoken to them, it's probably a little bit behind of when they should have met. I remember a couple months ago, I was getting ready in the cardiac OR and we get a call from the outpatient center. Hey, we have a blue patient here for tooth extraction. Can you guys do it? And I said, of course we can do it, but it probably should have been referred to us earlier. Long story short, we ended up fitting it in the afternoon and taking care of the patient. But baseline saturation of 80, coming in for a tooth extraction, and the oral surgeon didn't know anything about it, and this and that. But we made it work. So I want to know your medical history. I want to know your medical history other than just your heart. I want to know about your high blood pressure. I want to know about your shortness of breath. I want to know about smoking. I want to know about you having headaches. I want to know your medical history other than cardiac. Then we can talk about cardiac, because I have to manage all your disease processes. You're not a baby anymore. We all have acquired disease as we get older. Most common, of course, being hypertension, acquired coronary artery disease, these type of things. What type of medications are you on? The best thing you can do is just have it on a sheet of paper. Have it, your medical history, a list of medications on a sheet of paper. Do you have any allergies? This is something that sometimes people gloss over, but it's really important. And you may say, when I was a kid, I had something and I had an allergic reaction to it, but I don't remember what it was. And that's fine. At least it raises our awareness that you have this history of allergy. Airway. So if anybody has ever told you in the anesthesia setting that they had a hard time with your airway, has that ever happened to anybody? Well, okay, I think that's the first time it's never happened to anybody. What that typically means is we think about it in two categories. One is after you've been put to sleep, it means that we had difficulty breathing for you with just a mask. That's one category. The other category means after you're asleep, when we go to try to put a breathing tube in, it was less than routine. Typically, it's very routine. But that's something we want to know because there's special techniques that we can do. We can put it in with a little flexible camera. We can do it wide awake, which I like to try to avoid. We numb you up real good. It's not that bad. It's not that bad because I've tried to do it to myself. And I've done a TE to myself, which was probably worse than that. Smoking history is a big deal because I want to know how you're going to react when we're waking you up. Are you going to cough? Do you have a lot of secretions? This type of thing. And then the most important thing to me when I'm managing you is I want to know what your special concerns are regarding anesthesia. People either love me or they hate me, right? People either are very comfortable going to sleep or it freaks them out more than the surgery. I want to know if you had nausea and vomiting, if that's a big concern of yours. There's multiple levels of what we can do. Did you have a situation of awareness at some point in your life when you had a procedure? Super important. What about the anesthesia is causing you anxiety? And I guarantee you we can talk you through it. And if we can't talk you through it, we can get you through it real fast so you won't remember. Surgical history is important, but sort of as somebody mentioned earlier, you may know your entire surgical history, you may not know nothing about it. And we see this all the time. It ranges from actually having the surgeon's report from when you were a child or you had your repairs to absolutely nothing. And we're trying to figure out what happened to you. Do you have any residual defects? What does the imaging look like? I would love to talk to your cardiologist before we start the surgery. Know what their concerns are. Do you have any devices? Do you have a pacer? Do you have a defibrillator? And then sort of one of the easiest things is we talk about optimization before elective surgeries. Do you feel that you're at your baseline? Are you more fatigued than usual? Are you exercising great? You feel great? We like to have all these baseline labs. Your functional capacity, do you walk up a flight of stairs okay? Or are you getting short of breath doing the normal things you normally do? Recommendations, just for patients having non-cardiac surgery, it's a lot of sort of baseline stuff, but the bottom two are sort of the important things, or bottom three, that patients that are considered high risk are the ones we sort of talked about before: Fontane's, cyanotic heart disease, severe pulmonary hypertension, heart failure, patients with bad heart rhythms. It's great if you consult with adult congenital heart disease cardiologist before your surgery. They can communicate to us special concerns. And then consultation with a cardiac anesthesiologist is recommended for moderate to high risk. And then just 2 more slides. Anesthesia is individualized. I know we have the fast food model that we're moving towards medicine, or that, the powers that be want us to move towards, but anesthesia really is individualized. Everything from your drug dosing to the amount of monitoring we're doing for you, it's individualized based on you, it's based on the procedure, and it's based on the person doing the procedure. One person may be comfortable having a procedure done under light sedation, and then another person has to be completely asleep. And that's an individual decision, and that's something that anesthesia should be individualized. We alter the degree of monitoring based on sort of these 3 things also: patient, procedure, person doing the procedure. From anywhere from just a blood pressure cuff, we may put a little IV in your artery to look at your blood pressure. We may put in more catheters. We may do a TE when you're asleep. We have different ways of putting you to sleep. When you were a kid, you probably just breathed some gas through a mask and it was super traumatic because somebody was holding a mask on your face. Typically in adults that can tolerate getting an IV, we'll use IV medications to put you to sleep. Or if you need an inhalation induction, we can put some Tutti Frutti flavoring on the inside so it's not traumatic. Or cherry chapstick. We have different ways of maintaining you asleep that should be individualized to you. We have different ways of waking you up. And then post-operatively, which is we have a bazillion different ways to control your pain that can be individualized to you. And we have a bazillion ways of dealing with nausea, vomiting, et cetera. Any of the concerns you have that you've communicated to your anesthesia team should be individualized to you. And then I guess we'll do questions at the end. Thank you.